Ampok. So today, Dr. Sridhar will be presenting a case of CA breast. I think like we all know that breast cancer is the most common cancer, and for any DM exam, it is definitely going to be the long case. So more and more the number of times we present, it is going to be beneficial for the students. So today we have Dr. Ashok and Dr. Rahul as the examiners. So I request them to take over the proceedings. Over to you, Dr. Ashok and Rahul.
Thank you, sir.
So can I start, sir?
Yeah. Please go ahead.
Yes, please.
Good evening. So today I'm presenting a case. My patient is a 42-year-old woman who's a resident of Kozhikode, Kerala, homemaker by occupation. She presented with chief complaints of a swelling in the left breast for the last 2 years, which was associated with nipple discharge for the last 2 months. Coming to the history of presenting illness, patient was apparently normal 2 years back when she first noticed the swelling in the left breast. It was insidious in onset and small in size at the outset, but has gradually progressed to its current size. It has been associated with intermittent nipple discharge in the last 2 months. Discharge occurred spontaneously, was bloody in nature, minimal in quantity, no history of any associated pain, redness, or skin changes over the nipple or the breast. There was no history of any nipple retraction, no history of any fullness in the axil or the opposite breast, no history of trauma, no history of previous breast biopsies or surgery, no history of fever or pain over the swelling, no history of prior irradiation to the breast. There's no history of cough, breathlessness, chest pain, no history of abdominal pain, jaundice, no history of headache, convulsions, no history of bone pains, no history of any other swelling in the body, and there's no history of any significant weight loss. Past history, there is no history of diabetes mellitus, hypertension, cardiovascular disease, TB, bronchial asthma, no history of any previous surgeries. Menstrual, marital, and obstetric history. Menarche was attained at the age of 13, married at the age of 21. Regular menstrual cycles, the last menstrual period was on 1/4/2024. P3L3. First childbirth at the age of 23, breastfed for each child for greater than 1 year. No history of OCP use or hormonal therapy. Personal history, non-vegetarian diet, normal sleep patterns, no history of addictions. No history of any malignancy in the family, including breast cancer, ovarian cancer, prostate, or pancreatic cancers. So summarizing my history, it's a 42-year-old premenopausal woman, P3L3, with no significant comorbidities or family history, who presented with a slowly progressive painless breast lump since 2 years, with a recent history of spontaneous intermittent bloody discharge, a nipple discharge for 2 months.
So based on your history,
Yes,
what would be your provisional diagnosis here?
Sir, I would keep carcinoma breast as the provisional diagnosis.
Okay. Can you perhaps make an indicated guess as to what type of subtype of breast cancer this is?
Since it's a long history, it would possibly be a hormone-positive breast cancer, hormone-positive HER2-negative breast cancer, because it's a long history, slow, and there is no other signs of the clinically or history-wise, there is no sign of the disease being metastatic, or there is no signs of history suggestive metastatic spread. So hormone-positive HER2-negative would be a clinical diagnosis.
Right. Yeah, but only answer that if you are asked directly. Otherwise, when you are asked for provisional, you just say that it's a possible case of carcinoma breast and that stop at that. So there's no risk factors in this patient, right?
No, sir.
No family history also.
No, sir.
Okay, you can go ahead to examination.
So coming to the general examination, the patient is conscious, cooperative, oriented to time, place, and person. Vitals, pulse rate was 78 per minute, regular rhythm, nominal volume. BP was 130/80 in right arm supine position. Weight was 70 kg, height was 164 centimeters, BMI was 26, and BSA was 1.78. The ECOG PS was 0. Patient is afebrile on examination. There is no pallor, icterus, cyanosis, pedal edema. There's no localized bony or spinal tenderness. Bilateral arms are normal. On examination of neck, there is no palpable nodes. Thyroid is, there is no
I'm sorry,
palpable.
what do you mean by bilateral arms are normal?
So basically, whether any edema, we are looking for signs of lymphedema or swelling, redness of the arms.
Okay. So this is your general examination, no?
Yes, sir.
So as per McLeod or Hutchison, I don't think these things come into the picture.
No, sir.
Pallor, icterus, field edema, and lymph nodes are all acceptable.
Yes.
Cyanosis has no role over here. Field edema, yes, but if there is lymphedema of the arms, you should mention it only if it's positive. If it's not, you can just avoid it. That's
Okay,
my opinion, because if you're going to follow something, it should be based on one of the standard examination texts.
yes, sir.
Right. Go ahead.
Dr. Sridhar, just a minute. Please, kindly refrain from using short forms like, ECOG PA. Please give an expansion of all the abbreviations. And why do you call this patient as ECOG PS0?
So there is no, the patient is able to carry out all pre-disease, in the pre-disease state, whatever activity she was able to carry out, there is no restriction of any activity, both her day-to-day activities and strenuous work-related activities as well.
Okay.
So
Proceed.
coming to the breast examination, so inspection with arms, sitting position with the arms by the side. The left nipple areola complex appears slightly higher than the right. There is a large irregular swelling involving the upper outer quadrant of the left breast. No scar sign is there, dilated veins, erythema over the swelling over the left breast. No active nipple discharge or retraction is noted. On asking the patient to raise the arm over the head, both breasts move upward symmetrically. Swelling over the, again, the swelling is noted in the upper outer quadrant of the left breast. Inframammary crease appears normal. The left axilla, right breast, right axilla, again, bilateral arms. On inspection, there is no abnormality, no lymphedema, and no obvious fullness or swelling noted. On asking the patient to bend forward, both breasts falls forward. Palpation was done in the supine position. The right breast is normal on palpation. On palpation of the left breast, there is no local rise of temperature. It is non-tender. Inspection findings are confirmed. That is, a large mass, size of 5 into 4 centimeter is palpable, involving the upper outer quadrant of the left breast. Irregular in shape with irregular margins, firm to hard in consistency, mobile with the breast tissue, not fixed to the underlying chest wall of fascia, no pure orange appearance. Edema, and the skin over the swelling is pinchable. Examination of the axilla. Swellings are palpable in the left axilla, the anterior group, 2 into 2 centimeter, non-tender fixed node, and another 2 into 1 centimeter, non-tender, mobile, firm to hard node. The right breast axilla on palpations also is normal. Coming to systemic examination, per abdomen is soft, non-tender, no organomegaly. Respiratory system, bilateral normal vesicular breath sounds, no added sounds. Cardiovascular system, the S1, S2 is heard, no added murmur. CNS examination, higher mental function is normal. Cranial nerve, motor sensory examinations are within normal limits. So summarizing, again, a 42-year-old premenopausal woman, P3L3, with no significant comorbidities or family history, presenting with a slowly progressive breast lump of 2-year duration with a recent history of spontaneous intermittent bloody nipple discharge for 2 months. On examination, with having a 5 into 4 centimeter hard, irregularly shaped mass palpable in the upper outer quadrant of the left breast associated with axillary lymphadenopathy.
Right. So what's your clinical stage?
So stage will be T2 into AM0.
So stage 3, 3A.
Yes, 3. Yes, sir, 3A.
Right. So how will you investigate this patient?
So we can group the investigations into diagnostic for tissue diagnosis, staging investigation as well.
Let's do something here. Let's try to go forward as if the patient is in front of you.
Okay,
So the
sir.
patient has come to you, you've done your physical examination, you've done your history, and you've got your provisional diagnosis. You want to move forward and get things going. So
Yes, sir.
what are the things you'd like to? You don't have to group it in. What would you like to do?
So first, we would need a tissue diagnosis. For that,
Right.
we would get a true cut biopsy of the breast swelling.
Okay.
along with a 3-mark IHC panel for the ERPR HER2 status.
You don't want K67?
K67 also. ERPR HER2 K67.
Do you want an FNAC from the axillary node?
So ideally, we should get an FNAC from the auxiliary
No,
node.
let us speak. Do you do it routinely in your practice, in your hospital?
Routinely, we are not doing FNA for all auxiliary nodes, sir. Because T2, I mean N2 nodes, we generally, if it is a very
No problem. If it is N2, you don't need to do it. That is entirely left up to you. So you'll
Yes,
get a true cut biopsy from the primary and plus minus FNAC. If you don't get also no problem. You have sent for IHC markers. What else?
we would like to get a bilateral mammogram, sir.
Okay.
And then for staging investigations, since it is stage 3 breast cancer, our institutional protocol is to go ahead with the PET-CT rather than
No problem. Accepted.
We go for a PET-CT, and we will also get a routine blood work done just to see the fitness of the patient, which includes a complete blood count, renal function test, liver function test.
Okay. She has no premorbidities, no?
No, sir, no comorbidities.
Okay. Right. Do you have the investigation results after this, or are we discussing from here on?
I haven't put up the results, sir. I mean, it
Okay.
was done,
Right.
but
So let's say that you have this patient is ERPR strongly positive, HER2 negative, K67 of 15%,
yes, sir.
1.5.
Yes, sir.
You've done your bilateral mammogram. It's slightly more than 5 centimeters, so it's a T3 and 2 disease.
Yes, sir.
Again, the stage doesn't change. It's still 3A. You have done your PET scan. There is no evidence of distant metastasis.
Yes, sir.
How do you want to proceed?
Sir, stage 3 disease, we would like to proceed with neoadjuvant chemo, followed by neoadjuvant chemo, followed by clinical reassessment at the end of neoadjuvant chemo.
Okay. Is there any scenario in which you would send this patient for surgery?
Upfront, sir, upfront surgery can be considered.
Will you consider it?
I mean, stage.
Sridhar, think of it like this. You are in the OPD. You are the consultant. Patient is sitting in front of you. You've got your diagnosis. You got your reports. You have told the patient this. Now you have to tell her what she needs to do. As far as I know, I don't think that she might not be as educated as you or I, and she might be looking to you for opinions on what to do. But natural tendency for most people is to say, okay, I've got a cancer, it's not spread, just take it out. So
Yes, sir.
so is that something you would consider? That's a question here.
So
You have two ways out of this. You can either say what you feel is correct, or you can say, I'll refer to the tumor board.
we can discuss in a multidisciplinary workup.
Okay, there is no need to discuss this case if it was me, I wouldn't even discuss this in a tumor board. Our tumor boards are kept only for patients in which we have difficulty in a diagnostic dilemma or a management dilemma. In this, it's very straightforward. She has a fixed node. There is no way you're going to send this for surgery. You
Yes,
have
sir.
to give neoadjuvant chemotherapy. So when you're sure of that, you have to be very confident and you have to tell that, no, I will go for neoadjuvant chemotherapy.
Yes, sir.
Nobody is going to fault you for saying that confidently. Okay.
Yes, sir.
Right. So what neoadjuvant chemotherapy are you going to give this lady?
Sir, anthracyclines, 4 cycles of adriamycin cyclophosphamide, followed by 4 cycles of docetaxel.
Docetaxel.
Docetaxel or weekly Paclitaxel can be considered, but 4 AC followed by.
So is there any trial that compares the two?
Sir,
Do you know any trial that compares the two?
it has been shown that weekly Paclitaxel is equivalent to 3 weekly dosi, but weekly dosi, I mean, non-inferior.
Do you know the trial?
Sir, I don't remember the trial.
ECOG 1199.
Yes,
One
sir.
of the very few trials that I remember from my DM days. It showed that weekly paclitaxel, 12 weekly paclitaxel is actually superior, at least in PFS, if not in OS. Anyway, whatever, you will give anthracyclines and some form of taxane.
Yes, sir.
Can you please tell me how you will write a prescription of what you just said, AC regimen?
Sir, AC would be
You have to tell from the beginning, including the pre-medication. See, the
first,
patient again, imagine you are in a small center, patient is in front of you, chemotherapy nurse is there, she will give whatever you say. So you have to write
yeah,
the chemotherapy protocol and give.
yes, sir.
So tell, how will you give?
Sir, first, pre-medication, so it is a high hematogenic combination. We would like to give if the combination of aprepitant or fosaprepitant with olanzapine with olanzapine and granisetron or MCET on the day 1.
Okay.
Followed by olanzapine to be continued on day 2, day 3.
So let me tell you how. So you know that it's a highly emetic agent. Let's
Yes.
choose one. Take aprepitant. Now,
Yes.
aprepitant can be given alone or in combination with olanzapine. Let's just go with aprepitant. Please tell me the dose of aprepitant.
Sir, aprepitant, the first dose will be 120 is the initial dose, followed by 80 on the next 2 days. 125 on the first day and 80 on day 2 and day 3, sir.
Yes, 125 day 1, day 2 80, day 3 80. Okay. Next injection you said granisetron. How much?
Granisetron 2 mg, sir, IV.
2 mg.
Sir,
2 mg IV or oral?
2 mg IV, IV, sir.
1 mg. Okay. Next.
Sir,
Only these
olanzapine.
two drugs?
Sir?
Olanzapine comes later. Only these two drugs pre-medication.
Sir, dexamethasone.
How much?
8 mg IV.
Right. And you will also give either ranitidine or pantoprazole or something like that, right?
Yes, sir.
Okay. Now you tell me how you will write the prescription for AC regimen, anthracycline and the cyclophosphamide.
Yes, sir.
Doxorubicin, cyclophosphamide.
Doxorubicin is given in 60 mg per meter square as an IV push bolus, sir, in over IV bolus over 10 minutes, under 10 minutes is what we give, sir.
So you will just put a cannula in her and you will give IV bolus of
So the location of the cannula should be
that will be proper. Location is on the fleshy side of the forearm. No, not over any joints, not over any bony prominences. There is a good backflow. All that is settled.
yes,
So
sir.
with that, you will give 60 mg per meter squared IV push.
Sir, in 100 ml NS.
In 100 ml NS.
Over
It is
10.
written in the it is written in the package insert, and it's written in the books also. Now, there is a very important reason why I'm asking you this. After studying all these hi-fi trials for my DM final exam around 9 years back, I was asked this exact same question, and I fumbled just like you did. So the learning point here is know the basics, then learn all the big trials.
Yes, sir.
Doxorubicin is given 60 mg per meter squared over IV bolus over a fast flowing IV saline line. So you put in a 500 ml or 100 ml NS, put it on into the cannula, put it on full flow, use a 3-way port and then push it in.
Yes, sir.
Okay, this is how you give doxorubicin. Cyclophosphamide, you know, no?
Yes, sir.
600 mg per meter squared over?
Or 30 minutes, sir.
30 minutes.
Yeah.
Okay. Right. It's 60 minutes. Okay. It doesn't matter. That's fine. 30 minutes, 60 minutes is fine. But this is the things that they will catch you on. Some people.
Yes.
Okay. Right. So anthracycline you gave, taxane you gave. And you told her you go and come back. When you are going to call her back for the second cycle?
So before the second cycle, we would call her for a review at 1 week with us
Okay.
complete blood count to see how she has tolerated the previous therapy.
And
And
you will obviously be giving growth factors.
yes, sir.
Fine. Now, when my question is, when will you call her for the second cycle?
Sir, 21 day cycle, sir.
Are you sure? So is
Yeah.
that the standard of care now? In a 42-year-old premenopausal lady with a locally advanced breast cancer, whatever be the type, hormone positive, triple negative, whatever it is, what is the standard of care? Category 1 recommendation.
Dose dense 2 weekly
Yes.
cycles.
Yes, you have to say dose dense
Yes.
AC. Okay. So it is so ideally you should have told, sir, in this patient, I will give dose dense AC 4 cycles followed by dose dense paclitaxel 4 cycles or 12 weekly paclitaxels. Usually weekly paclitaxel is a little more difficult to tolerate. There's also logistics issues involved. It is, but it's entirely up to you. If you want to use weekly, you can use. If you want to use dose-dense Paclitaxel, you can use whatever you want. But there's very clear evidence to say that dose-dense regimen must be used, especially in the neoadjuvant setting.
Yes, sir.
Okay, right. So you have given Rahul, anything to ask?
No, basically, just like, if you falter on those dilutions and how you give it, then definitely you'll get, other nagging questions like what is the color of doxorubicin? Have you seen a cyclophosphamide vial and all these things? So please be prepared for those kind of questions as well. For what do you consider if this patient has come to you for cycle 2 of AC, and even before coming to your hospital or the moment she sees you, she starts puking. So would you consider something in the antiemetic regimen for her, apart from the aprepitant and dexamethasone and things like that?
Sir,
So what Dr. Rahul is asking is, you gave AC. She went home. After next day, she had vomiting. After that, she felt better. 2 days before, 1 day before, 1 or 2 days before she was supposed to come to you, again she started vomiting. How will you modify your pre-medication and post-medication?
sir, we generally consider giving lorazepam on the day of chemotherapy because this is anticipatory
Yep.
vomiting.
Correct.
Or even a day before also you can give. Yes, right. Yeah, that's it from my side. Yeah, you can proceed.
Right. So you've given your 8 cycles of chemotherapy.
Yes.
And you have reassessed, and the patient is found to have partial response. Anyway,
Yes.
the nodes have become from fixed, it has become 1 or 2 lymph nodes that are mobile. You're going to send for surgery. So
Yes, sir.
one thing I wanted to ask you is, in this patient,
Yes, sir.
would you consider neoadjuvant hormone therapy?
The neoadjuvant hormone therapy can be considered only in patients who are not fit for chemotherapy.
Right.
If fit for chemotherapy, we would not consider neoadjuvant hormones.
Okay. So let's just change this. Say, suppose it is a frail 75-year-old lady.
Yes, sir.
And you don't think that and she has some heart disease also. So you don't think she's going to tolerate chemotherapy.
Yes, sir.
So she's postmenopausal. So naturally, you're going to give neoadjuvant hormones in the form of one of the aromatase inhibitors, right?
Yes, sir.
So the question is this: how long will you take before you reassess?
Sir, neoadjuvant hormone should be given for at least 6 months or till
Correct.
max clinical response.
Yes. So that is the point here. Chemotherapy, you have faster response. You're going to finish the entire cycles of chemotherapy, the 8 cycles, dose ends within 4 months. But if you're planning to give on hormone, neoadjuvant hormonal, you should wait for at least 6 months before sending for surgery. In the meantime, close follow-up to see whether there is a progression in between therapy.
Yes,
On
sir.
therapy. Right. So you send for surgery. Again, the the pathology report has come as. So how will the pathology report come? What will be the, let's say I'll give you the details. So you see that there's only a single node which is involved by tumor, and there is a 2 centimeter residual mass in the breast. What is the stage?
So one node pathological PN1
Hmm.
YP YP
Yes.
T stage size, sir.
Okay, I'll make it easy for 1.8 centimeters. So YPT,
T1 1.8 T1C.
yes, YPT1C N1A M0. Okay, at this point of time, what would you like to do? She has come to you for advice. What are you going to ask her to do?
So the adjuvant radiation, since she's node positive, and adjuvant hormone therapy.
Okay, a patient has underwent a mastectomy instead of a BCS.
Sir.
So what is the next step? Patient has T1C N1A single node positive YP,
Yes, sir.
and the patient has undergone a left total modified radical mastectomy.
Do you want to give adjuvant radiotherapy or not?
In this
That's the
patient,
question.
that
Yes.
is what I'm asking.
Yes.
Simple, no? Yes or no? You can pick one.
Sir, yes, sir. We'll go ahead with.
Why?
It is initially node positive, and it has not become N0. It is still N1.
Yes. It is not only node positive, it is an N2 disease. There was a fixed node. So whatever she does, it doesn't matter if it is left radical mastectomy with axillary clearance, axillary dissection, whatever they do, even if they clear L1, L2, L3, all levels, you have to give adjuvant radiotherapy.
Yes, sir.
Okay. So that's a must. Next, you will ask for hormone therapy. How are you going to give hormone therapy? Radiation, she's come back to you. She's in front of you.
Yes, sir. Sir, hormone therapy can start with tamoxifen at 20 mg once daily dosing, along with she's tamoxifen for a minimum of 5 years, but she's stage 3 and node positive. So extended hormone therapy for up to 10 years with switching over to inhibitors after 2 5 years can, or 2 to 3 years of tamoxifen can be considered.
So in this patient, you are saying that you will give for say 2 to 3 years of tamoxifen and then switch to say letrozole for another 3 to 5 years. Am I correct?
Sir, yes, sir.
Nothing else.
Something you want to do with the ovaries?
Sir, OFS, but the benefit with OFS was seen in a younger population, less than 35. So she's 42, and
is she premenopausal or not?
She's premenopausal, sir.
Okay, so you are saying that the benefit is there only under 30 years and not in say 30 to 45 years.
So the maximum benefit was seen in the up to 40 years age group. She's more than 40.
So she's 2 years above your cutoff. So unfortunately, or fortunately rather, she doesn't have to do anything for her ovaries. Correct? No, you just said a cutoff of 40 years, right?
Yes, sir.
Okay. So this is for what is your data and what is your source?
Soft and express.
What did soft index say?
So the addition of OFS plus aromatase inhibitors showed benefit in the younger population who are hormone
What
positive,
else? What else?
node positive.
Yes. Is she not positive?
Yes, sir.
Then what else?
Means node positive.
So there are very few trials in which you have to read extremely well. You have to read in and out. And you yourself have brought yourself to this because there is no way, I think, if there's any consultant in this audience, there is no way any consultant is going to let this patient go back without an ovarian function suppression. Okay, definitely she's going to get ovarian function suppression. She is a stage 3A disease. She is only 42 is also young. Okay. See, the thing is, in India, we see patients who are like 30, 25, 28, and we think that only those are the bad tumors. In any Western country, a 42-year-old breast cancer is a catastrophic diagnosis. People would be shocked. Even the consultant or the attending will be taken aback. It's not common to see this. So just because we are used to it in a younger age doesn't mean 42 is a okay age to have breast cancer. Okay, breast cancer is at 42 is still pretty bad.
Yes, sir.
Stage 3, definitely you have to give OFS for this patient. What OFS we'll come to later. Now, the variables that text and soft said were major, the max, like you said something, the variables that had the highest correlation, right?
Yes, sir.
So that was age less than 30, 35, I think.
Yes, sir.
Node positive more than or equal to 4 nodes, and grade 2 or grade 3 tumor. This is, let's assume that this is a grade 2 tumor. So there are two variables in text and soft that say very clearly that you should give OFS. One, there are a lot of other variables which did not have as much correlation, but were also found to be significant. Size of the tumor, the progesterone receptor expression, and even the Ki-67. These are all factors that were taken into consideration. So there's no doubt that you have to give this. Now, actually, I thought you will definitely say OFS, and I was going to ask you whether you will give tamoxifen or letrozole for this patient. Is there a difference?
So with OFS aromatase inhibitor, letrozole plus bisphosphonates can be given. So
With OFS, you would give letrozole, not tamoxifen.
yes, sir.
Okay, so I'll give you an overview. I don't know. I mean, this is my understanding of text and soft trials. I may be wrong. You go and read and form your own conclusions. So text and soft says that in premenopausal ladies, when you have these variables, if basically any premenopausal lady with a tumor size more than 2 centimeter or less than 35 years or node positive, any node or grade 2 or more, you have to give OFS. Now, they checked out if there was a difference between letrozole and tamoxifen. There was a comparison. So what
Yes,
they
sir.
found was there was a very slight benefit for letrozole.
Yes, sir.
Not as much as with tamoxifen.
Yes,
So
sir.
one thing they proposed is when there is a node, when these criteria of the highest, that variable of the highest correlation, no, those three things. If
Yes,
one of them were positive, you are better off giving letrozole than tamoxifen.
yes, sir.
So, for example, if this was a grade 1 tumor with 2 lymph nodes at diagnosis, not after treatment, 2 lymph nodes, palpable lymph nodes, mobile lymph nodes, they're basically an N1 disease at diagnosis. Maybe it was a T3 tumor and N1 disease, and the age was more than, age was 42 only, and it was a grade 1 tumor. Now, none of those things are there. then
Yeah.
maybe you're justified in giving OFS plus tamoxifen. But anything more risk than that, you should give OFS plus letrozole.
Yes, sir.
That is my understanding of the text and soft, especially the updated analysis. Okay, so how will you give OFS?
Sir, OFS leuprolide, we are in our institute, we generally give the 3 monthly dosing, not the monthly.
What's the dose? What is the dose? What is the dose of leuprolide?
Sir, not 3 monthly, we give 6 monthly. Uh,
Okay, what is the dose of 6 monthly leuprolide?
uh,
You have to tell me the dose written in the package insert or from the FDA website.
Sir, the 22.5
1 to
mg,
6 months.
6 months, sir.
Okay, you're wrong. Okay. The package insert and the actual dose of leuprolide should be 22.5 every 3 months or 45 mg. Eligard is the only one used to come with 45 mg once in 6 months. That is the actual dose. But in general, most of the consultants give 11.25 every 3 months and 22.5 every 6 months. Personally, I have given 11.25 for a long time because of the cost issues. And I found that the ovarian function suppression that we used to check in the FSH-LH ratios and not, that used to be fairly well suppressed. So it was fine. But the actual dose, when somebody asks you what is the dose of this drug, answer of leuprolide is 22.5 3 monthly or 3.75 monthly or 45 6 monthly. Now,
Yes.
was leuprolide given in text and soft trials?
Soft and goserelin was given, sir.
Goserelin.
Goserelin,
It
sorry,
is
sir.
it is triptorelin which is given.
Goserelin.
Triptorelin.
So, Sridhar, you have to read the trial properly, in and out. Every word, every in between line you have to read because it's complicated, it's difficult to understand. I suggest you meet your consultants if you have any difficulty in understanding any certain parts of it, like what they meant when they said that, there was a increase in hazard ratio when the tumor is more than 2 centimeters. What should we give in such a case? Those sort of things you should discuss. Okay.
Yes, sir.
So, text and soft used triptorelin.
Yes, sir.
Anything else they used? What were the methods of OFS in text and soft trials?
Sir, radiation,
Yes, and
ovarian RT, and
surgery.
surgery. Yes, sir.
DSO. Okay. So out of their extended analysis, there is evidence to state that the least effective is radiation. So most centers do not offer radiation.
Yes, sir.
So if a patient comes and we explain the concept of OFS and they ask us what to do, either take the ovaries out or give one of the GNRS analogs. We are not going to give radiation because it doesn't have as good efficacy as the other two in causing an ovarian function suppression. Right.
Yes, sir.
And then you told about a number of years that you will use, no? So suppose you start on letrozole, like for this patient. So let's assume that you start on OFS and letrozole. How many years you will give?
Sir, the endocrine therapy will be continued for at least 7 to 10 years, sir. And OFS for 5 years.
Trial shows which trial there was data for 10 years of letrozole.
Extended hormone therapy for up to 10 years.
Agreed. There is something called extended hormone therapy. That is for 10 years also. But
Yes.
this patient, you are starting on letrozole. Do you want to give letrozole for 10 years for this patient? No, there is in my to the best of my knowledge, there's no trial that shows that has looked at 10 years of letrozole, and that has become a standard of care anywhere. What has happened is they have looked at 5 years tamoxifen, 5 years letrozole. They have looked at 2 years tamoxifen, 2 to 3 years, like you said in the beginning, 2 to 3 years of tamoxifen followed by letrozole. And there was one trial, INT something trial was there, that showed that extending letrozole. So you give 2 years of tamoxifen, and instead of 3 years of letrozole, if you extend it to 5 years, that is a total of 7 years of hormone therapy, there is a significant benefit.
Yes, sir.
So if you are, so the standard practice, what I understand in most places is that if you're starting with letrozole, you tell the patient upfront itself, you tell the patient. Some people come and ask, sir, it's 5 years, we are going to stop it. And then you can't tell them, see, there is other evidence saying that there is it should begin for 7 years or not. So you tell in the beginning, this should be continued for 7 years.
Yes, sir.
How long are you going to continue OFS?
That 5 years.
Why 5 years? Why not 7 years? So the correct answer to that question is unless she is postmenopausal.
Yes, sir.
So what you do is, after if the patient you have started on any OFS, after 2 years she is still amenorrheic,
Yes, sir.
you can check, you can take you can skip 1 dose of the letrozole, maybe push it around 2 or 3 weeks later. Then check their FSH, LHH, estradiol, see whether it is in the postmenopausal range. If it has come to postmenopausal range, you can stop the OFS and you can continue only on letrozole. Got it?
Okay, sir.
Right. So, how will you follow up this patient? NCCN guidelines.
Sir, follow up with the clinical examination and
Yes. How frequently?
every 3 months.
Every 3 months. Okay. What else?
And then we would get a chest X-ray and an ultrasound abdomen.
Okay. How often?
Once in 6 months.
Right. Mammogram?
Once in 6 months initially, and then yearly once after 1 year.
Once in 6 months, sir.
Year,
Mammogram.
yearly.
Okay. Mammogram is once a year. Okay.
Yearly once.
Know the okay. Can you tell me the how you will do screening mammography according to whichever guidelines you're following, US or ESMO or whichever one? When will you start? Till when will you do mammography? Because you said 6 months, I'm asking. So for a general population, not a patient, not a case of breast cancer, how frequently will you do a mammogram?
Sir, from the age of 40 years, yearly once.
Age of 40.
Yes, starting from the age of 40 years. If there is no risk, I mean, if it's a increased risk.
Which guideline is this? ACS, US Preventive Task Force, NCCN. Okay,
Yes.
so it's like this. What I remember is 40 to 45, you have to individualize.
Yes, sir.
Okay, if there is some distant family history, or if there is some other reason that you want to start early, you can start. If there's history of some radiation or something, you can start early. 45 onwards, yearly mammogram till the age of
75.
Yeah. So yeah, some say 70, some say 75, after which you make it once in 2 years.
Yes, sir.
After the age of 75, I think it's not required.
Yes, sir.
Right. So how will you know this patient is achieved menopause? So that you
Sir,
can the
patient on OFS, it is not possible to determine whether they have attained menopause.
what's so hard?
Uh,
Simple, just skip one dose, no?
In fact, sir has mentioned before, skip a dose of leuprolide. After a month or so, just check the E2 FSH level.
Just skip a dose, and the suppression should wear off enough. And if there is some residual estrogen production, it should show up in our FSH LH values.
Yes, sir.
And if it is postmenopausal range, you stop it. That's all.
Yes,
So
sir.
I stop for patients after 1 year of office because they went into postmenopausal and they were having symptoms. They were having proper postmenopausal symptoms. Usually they have it with GnRH analogs also. But for the patient I'm talking about, her hot flushes and all suddenly aggravated. So I thought I'll just check it, and it turned out to be postmenopausal. You can just skip a dose and then check.
Yes, sir.
Right. Dr. Rahul, anything else to ask in this?
Yeah. What do you do if the patient complains of hot flushes? Any drug that you can offer for hot flushes?
Sir, I'm not sure, sir.
You can use venlafaxine, it helps.
Yes, sir.
And is there any screening guidelines that you're aware for India? Or something, some guidelines for low middle income countries?
No, sir.
Okay, so the National Cancer Grid has also given some guidelines on how we can do on a limited resource setting and optimal resource setting. So in limited resource setting, they suggest a clinical breast examination is also a valid screening tool, especially for a country like India. And if you have an optimal resource, then you can use mammography every 2 years. The age stands the same.
Yes, sir.
Okay. Yeah, that's it from my side.
Right.
Do you want to do BRCA testing for this patient?
Sir, BRCA testing, it is again under 50 years breast cancer, it can be considered, but she does not have any other risk factors, no family history, but can be offered to the patient. If it was a triple negative breast cancer, any age we would consider
Yes.
BRCA.
Yes. Or even if it's a recurrent also, but age less than 50, NCCN says it's suggested.
Yes, sir.
But it needs to be offered. Of course, you need to discuss that option as well.
Yes, sir.
In the various types of breast cancer, no?
Yes, sir.
You have hormone positive, triple negative, HER2 positive, and the so-called triple positive and all that.
Yes,
So,
sir.
in which subset is BRCA mutation most commonly seen? Or rather, in which, if you take 100 patients of breast cancer,
Yes, sir.
of BRCA positive breast cancer, how many of them, which will be the maximum number of patients? Which subset will have the maximum number of patients?
Sir, triple negative breast cancer.
Okay, so that's a trick question. It's wrong. So the idea is that BRCA positivity is more commonly seen in triple negative. So you take 100 patients of triple negative breast cancer,
Yes, sir.
you will see a higher percentage which is BRCA positive, and
Yes, sir.
hormone positive is less.
Yes, sir.
But the incidence of triple negative is much less as compared to hormone positive.
Yes, sir.
So when somebody asks you what is the most common subtype in which you see BRCA positivity, it is actually hormone positive breast cancer because of the higher numbers involved.
Yes, sir.
Even though BRCA is very closely correlated with triple negative breast cancer.
Yes, sir.
Okay.
Yes, sir.
So it's basically a trick question. I mean, some places will do anything to see you trip and fall.
Yes, sir.
Right. I think we can wind up, Rahulji.
Yes, yes.
I think that's fine. Yeah. So, my comments on this, your history examination is excellent.
Yes, sir.
Your summary was very good. Everything, all those things went well.
Yes, sir.
So you need to start thinking, which year are you, DNB?
Sir, going into final year, sir.
Okay, then you definitely have to improve, because now you have to start thinking like a consultant.
Yes, sir.
So that's why I asked you. You have to imagine sitting in front of the patient and the patient is talking to you. You have nobody there. You don't have your consultant nearby. You are alone and you have to handle it alone. Okay,
Yes.
so think of it like that, and your decisions must be based on some evidence, and you should stick to that. And there are some trials in which they are called landmark trials for a reason.
Yes.
So, for HER2 positivity, Neosphere, HERA trial, and all those things and all, you should know. As a final year, you should know. If you're first year, no problem. Text and soft. There is literally, I think, no trial more important than text and soft as far as hormone positive, non-metastatic breast cancer is concerned. So, those and all you have to read up a little more. And the guidelines you should follow, and there should be, you should be able to say, okay, this is my reasoning. Okay, it's given in NCCN, or it's given in ESMO, or it's given in such and such thing. You have to have some sort of backup. And if there is some ambiguity, you can fall on to saying that, okay, this is my institutional protocol. That's fine. So that is how I escaped, because for my exam, they asked me, how do you give anthracycline? I said some crap about being given over 2 hours or 4 hours to reduce cardiac toxicity. And they were looking at me as if I was, till then I was answering all about these trials and all. Suddenly the simple question I couldn't answer. Luckily, my professor, Dr. Govinda was there. He told me that he told the examiner external that, yes, this is my protocol. I am using it like this. So I was saved. So institutional protocol is something you can fall back on. But then you should know what is actually happening also. Sir, actually it's given like this, but in our institution, we do like this. No problem. Nobody will penalize you for that.
Yes, sir.
Okay. So, Rahul, anything to add?
Yeah, no, in fact, you have covered all the things. It's a well, you have presented a case very well. You just need to, rationalize each and every questions which we ask. Why are we asking this particular question? Yes, you need to go on your trials. I very well agree with Ashok sir on that case. You need to go in depth in your trials. You need to actually dissect the trials, all the landmark trials. So many a times, certain examiners do have their favorite kind of practice when it comes to giving adjuvant treatments and things like that. But you need to rationalize out why you're using it. And the best way is to say that, sir, in our department or in our hospital or in our institute, we practice like this. In that case, definitely they'll ask, is there any other way where you practice, or is there any other options? Then you can, of course, you can answer that. And please go through your chemotherapy setup and try mixing the drugs. Please read the pamphlets. Look how the color of the drug is and how you mix it. Then you need to know, of course, the common side effects of the drug. So these are certain things which they will ask. So please don't make any mistake on it. So if you make a mistake, then the examiner gets an impression that you have never gone to the chemotherapy ward and you have never done a drug mix in your life. So please be careful on that one part of it. But otherwise, rest all is very good.
Thank you, sir.
This institution protocol, no? So there are some institutions that still give FEC.
Yes.
Even though there are multiple trials that prove that 5FU does not add to clinical benefit and adds only to tox. But
Yes, sir.
still, nobody will penalize you if you say that this is my institutional protocol. And that has happened also in certain institutions. There's no problem. It's not wrong also.
Yes, sir.
Yeah, in the UK, they still practice FEC.
Yeah, there are many places that still give FEC. So you just have to know what the guidelines say and what you are doing. That's all. And that is enough to justify it. Otherwise, overall, it was a very good presentation. You've done well. Okay.
Thank you, sir.
Bhavan sir, thank you.
Okay. Thank you, Ashok. Thank you, Rahul.
Yeah,
I think
thank
we
you,
come of breast cancer was covered. So thank you, Dr. Sridhar, for the presentation. So we'll be doing a different case will be presented next month. So the updates will be informed to you. Okay. Thank you. Good night.
Good night.
Good night.